So I farm so hard the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's
What's
get
good,
paid.
fam? It's your host, Jim Pruitt, aka PharmD the ED, and I'm bringing you another episode of the Pharm So Hard podcast. Today, we have the first episode of recording of the year. I'm super excited to be going into 2025 after starting this journey in 2019. So I just want to thank everyone that's been listening to the podcast for this long. Those of us that's been able to see me in person, I came back from mid-year and it's like, hey, you the guy from Pharm So Hard? And I was like, so cool. So very excited to start this year off. And we have a special guest today. And you guys, when people are smarter than me, I don't do a lot of talking. I want to let them do the big thing. So go ahead and introduce yourself for the audience and we'll jump into this episode.
Hello, everyone. And thank you, Jimmy, for having me. My name is Daniella. I'm a second-year critical care pharmacy resident. I did my pharmacy school at the Lebanese American University. So that's LAU in Lebanon. And so, now I'm resident. I'm excited to be here.
Perfect. So we're going to be talking about something I never in a million years thought that we will be chatting about. We're going to be kind of switching gears here. And of course, all of us in the ED have some critical care in our backbone. And all of my critical care people, they know that this is something that they've been talking about quite a bit. Talking about really the SGLT2 inhibitors and just their use in general, and really their use in the ICU. And we're going to really be diving into a few studies a little bit, but we're really going to spend most of our time talking about one particular study and what impact does it have on us. So when you see that order come across, and instead of you just denying it or putting the I event on there, you may want to verify it after we get done talking today. So let's go ahead and just, for those who are not super familiar with SGLT2 inhibitors, a lot of us were in school or in residency when they became popular and we just kind of wiped out of our head because we didn't think we needed them for the ED. Can you just reintroduce us to SGLT2 inhibitors and really talk about their different effects that we probably forgotten about?
Mm-hmm. Yeah, so SGLT2 inhibitors are actually one of my favorite classes. I feel like they can almost do everything. So the way they work is we have the SGLT2 transporter in our kidneys, and that helps reabsorb sodium and glucose into our body. And so when we inhibit that, we just release that glucose into our urine. And so we have less glucose in our body. So that helps with diabetes. So initially it was just an anti-diabetic drug. And I thought it was interesting how we even came about to even test it for cardiovascular outcomes. And so in 2008, the FDA mandated that all of the new anti-diabetic drugs just need to be tested for cardiovascular outcomes after what we saw with rosiglitazone and the safety outcomes with that. And so when we were testing the SGLT2 inhibitors for cardiovascular outcomes, we didn't just see no harm, but we actually saw a benefit. And so that's where it all started. So not just an anti-diabetic effect, but we even see a cardiovascular benefit. And then after that, even benefits in chronic kidney disease as well.
And that's really cool because I think sometimes I like to associate things with drugs that are already used. And anytime I've ever heard of pleiotropic, it's always been associated with a statin.
Yep.
It's always been really associated with that. So we start talking about all these different components of this pleiotropic effect.
Mm-hmm.
Can you tell the people what those potentially could be? Because again, you mentioned some of the renal components, but again, there's a lot that it can probably do, like from the cardiovascular standpoint, and people are very particular. So they have to hear, okay, it does this, it does this, it does this. Can you really help us understand some of the other components of the drug that really make up that pleiotropic effect?
Yeah, so it's not just like the mechanism of action, like we just talked about. The other effects that we found that we hypothesized that they also do is like adrenergic tone modulation, some anti-inflammatory effects. It was even interesting. I was reading about this fasting mimicry state that these drugs do. It's where, because when we're releasing that glucose, our body has less of that. And so we start to metabolize our ketones, and then our heart cells start to use that as an energy source. And so it helps improve like energy metabolism of our cells, which is pretty interesting.
Yeah, that's going to be pretty cool. Just understanding that, okay, not only are we just having this, when I think of these drugs, initially I was thinking, okay, well, you just put a bunch of, sugar in your urine, that's going to be kind of the big thing. But I didn't think about, potential preload issues. I didn't think about affluent reduction. I didn't think about reducing some of these levels of like inflammatory markers and like weight loss, like all these things that if you're going to be taking these drugs, you probably want to continue them. So it wasn't on my radar initially as something that we needed to really be focused on. So I'm happy you was able to kind of expand on that and really help us understand the kind of the background of how these drugs work. So again, I put it in my head, okay, now I have a statin-like drug, which probably could have some benefits that I'm not smart enough to understand across the board. So I'm excited about that. Now, there's also going to be some people who are saying, hey, Jimmy, okay, you've made a good pharmacologic, talking about these things. Can you tell us about any other studies? We have one we're going to talk about that we're going to defend our thought pattern on. But can you tell us about any other trials that included the SGLT2 inhibitors?
Yeah, so we actually have plenty of landmark trials for these SGLT2 inhibitors, and many of them found benefit both like for heart failure outcomes, CKD outcomes, and even like MACE outcomes, so non-fatal MI, stroke, death from cardiovascular disease. And so we have plenty of those landmark trials. Just some is like EMPA-REG, EMPA-REDUCED, EMPA-PRESERVed, DAPA-HF, DAPA-CKD. Those are just like some of the landmark trials that we saw some benefits. And they even got the FDA approval for those indications as well.
So that's the cool part. Again, we're bringing these things in, and these are critically ill patients, and we're going to be improving. When you start throwing a cardiovascular benefit in there and MACE and all my cardiology, they feel very smart when they throw MACE out there. And that's when the outcomes, because again, if you can take care of that, you're basically taking care of all the major things that we're thinking about. And these are not drugs that cause bleeding. So in my head, when I think of a MACE outcome, I think of like, okay, this is going to be okay, but I have to worry about the other side of the equation being bleeding. That's not necessarily the case with these drugs. So I think it's cool knowing that we have basically all the fancy trial names, the Pulse, the Impact, all of the M whatever, these drugs, and they really can help us from, heart failure exacerbation, even in the acute side of things. So for me, that's what I think about when we start going into the review of some of these trials, and there's even more. I think you sent me a document, and it was like 15 trials on there that was showing benefit of these drugs, and I felt a little I'm like, man, I probably should have like thought about this topic maybe years ago.
We have come a long way.
This has been a cool thing, other than, we get a patient in the unit and we're gonna go ahead and we're gonna hold these until patients stabilize. That was kind of the big thing. So it really set us up to chat about the big study that we're going to talk about, because it brought us to me, when I hear that the drug can do all these things, we have to turn around and say, okay, great. What is it doing in critically ill patients? Is there any study that you want to dive deeper into that really helps our people, assess this drug in critically ill patients?
Yeah, I would say before we start talking about the Defender trial, to talk about those trials that you're talking about. Mm-hmm. So there is studies that tested it in acute MI, acute heart failure, and even in COVID studies. And those were the ones that I wanted to talk about, because those are the ones that included potentially critically ill patients. Now, not all of them started them when they were in the ICU, but when they were clinically stable. But most of them actually did start it when they were not clinically stable. And so with those outcomes, we see really the outcomes weren't really there. They were more promising benefit instead of like a definitive outcome like we see with all our outpatient type of studies. But one thing I will point out is that we saw that they were safe to use in this acutely ill population.
And that's the big thing that I think sometimes we have to kind of get ourselves back around. The first things first, is it safe? And it seems now in the acutely ill patient, that was not necessarily the thought, but the data that we were able to see proved that consistently, even if the benefit wasn't there. So in my head, I have different buckets that I put interventions and drugs in. First is going to be, okay, this does no harm. That's the first step, because it does that. And then if it does no harm and potentially have some benefit, that's kind of my yellow zone. And it seems like we're kind of past that initial phase to this yellow zone. And we say, hey, this may actually be pretty beneficial without much harm. in critically ill patients, which is very different than you could have told me this 3 years ago. I'm like, hey, Jimmy, this is a safe drug to give, and it can benefit people in a variety of different ways, just like statins. So that's a cool thing to know that we have a decent amount of data. Again, much more than we have for drugs like ketamine, probably, and the drugs that we use every day in ED that we swear by. You have a ton of patients when it comes to these trials. So I was excited to kind of do some background reading and see some of this, and we'll put some stuff in a show note for you guys to go ahead and view to kind of have a deeper dive at that. But it's a lot out there, so I don't want to steal the thunder because we have some other stuff we want to get to. All right, so I want to switch gears to the study of the day and chat a little bit about that because I didn't know this study existed, and then you kind of brought it up, and I was like, okay, this is a good one now. So I want you to kind of let's go ahead and do a deep dive into this.
Yeah.
What do they do? Why they do it? What were their outcomes? Let's just get into some of the background and kind of the methods when it comes to this trial that you're gonna defend.
So yeah, Defender trial. The name was pretty interesting. So yeah, we just talked about how the potential benefits are in acute illness, like anti-inflammatory effects and all of that. So really theoretically, we do see a potential mechanism of it helping. And even there were some like experimental animal models that even showed like it can prevent some, kidney injury. So really theoretically, it could be plausible that this can have some benefit. What they did, this was like a multi-center randomized open label trial that they did in Brazil. And they got patients who were going to be in the ICU for at least 2 days. And they had at least one organ dysfunction. They either had like a cardiac, so they were hypotensive or they were on vasopressors, or they had some type of renal dysfunction where they had an AKI. And then the last thing was respiratory. So they needed some oxygen support. So they got all of these patient populations and they randomized them to either standard of care and they added dapagliflozin 10 milligrams daily for 14 days. They excluded patients who were type 1 diabetic, prior episode of DKA. So all of those like general concerns that we would have for SGLT2 inhibitors, they excluded them, which I thought was pretty reasonable. And they were looking at the primary outcome of a composite of hospital mortality, starting dialysis, and then looking at their ICU length of stay at 28 days.
All right. So they did that, got a good group in. When I looked at it, I said, okay, no major red flags. Because sometimes people like to play statistical gymnastics and move some things around, exclude certain patients, compare it to something that doesn't actually exist. So I was really, skeptical going in. But as we kind of went through the methods, some of the background, I said, okay, well, it looks like we got something that's legitimate and going to be an actually sick patient. So I was intrigued by that. So now that we kind of gotten the background and kind of understand outcomes, let's go ahead and talk about what did they find? What was the big juicy outcome that they was able to find?
So what was interesting, they used this win ratio, which they also use at one of the other SGLT2 inhibitor trials, which was the Impulse trial. And I thought the win ratio was pretty interesting because, when we have a composite, obviously, like if you're preventing mortality, it's going to be more beneficial than reducing an ICU length of stay by a day or two. And so the win ratio takes that into consideration where it has kind of like a hierarchy of we care about mortality the most and then preventing dialysis and then reducing ICU length of stay. So it takes that into consideration. And what they found was not statistically significant.
Good God. Well, just like probably most of the studies in the ICU, if you find a mortality benefit, you did some really, really good stuff. Like pressors don't have mortality benefit, which is wild, standard of care. So they didn't find that. But they did find something I thought was actually pretty cool. Can you talk about that?
Yes. So there was a type of signal, we can say, where we could see some benefit as for renal outcomes in terms of reducing the initiation of dialysis. So that would be a good signal.
And BICAR ICU trial kind of found similar stuff to that. We have plenty of studies that, and we know that if we can stop you from getting on dialysis, that's a huge, huge win. Because once you get on dialysis, it is something that's new. It's not that good of a thing, and you increase your chance of mortality by a significant amount. And again, Thank God for all my ICU people dealing with that stuff every day. Thank God I only have to do a little bit of dialysis. But all of your patients have a tube, a very big tube, either in their lungs or in their arms to act as a kidney, or sometimes even ECMO. So again, anytime they get on those big tubes, I say bad things happen. But again, knowing that a simple drug can reduce that, I think is cool. The whole wind thing threw me off a bit, to be honest. I was like, this is a little different, but it actually was. They did it to be more robust, but I think they probably could have made it a little bit more simple with a composite outcome. But the whole win percentage and stuff, I thought it was cool. I thought I was playing NFL. What my win percentage was. What about ICU length of stay? Did they find anything from that perspective?
And ICU length of stay, I didn't see it was statistically significant.
Yeah, so it wasn't any major difference with that either. So really, the only big thing I was able to capture from it was the fact that there's a nice little trend here towards those patients getting less renal replacement. So I thought that was kind of the big capture from this. And to me, when I think about, the key findings of this, again, I didn't see anything from a safety perspective to be concerned about, but it did show that trend, and it makes me want to say, what if I use just that as my primary outcome in my next study? Will that be something I can defend? What are some other thoughts you had from looking at this? Because it was a really cool concept I didn't think about.
Yeah, I actually wanted to also talk about the subgroup analyses. I thought was pretty interesting because when we're thinking about the theoretical benefit of like the anti-inflammatory and all of that type of benefit, we would think with the subgroup analysis of sepsis, maybe we would have seen more benefit in those septic patients versus the not septic patients. But when they did that subgroup analysis, they didn't see any difference. Even in the diabetic patients, there was no difference. Even like cardiovascular reason for their ICU admission, also no difference. And so I thought that was pretty interesting that we didn't see a difference with that.
Yeah, they really didn't find any major differences except for that one trend. Now, great study. They did some really cool things, but we wouldn't be pharmacists if we didn't really like critique it a little bit and address some of the limitations of the study. What were some of the limitations?
So some of the limitations I would say is that, so it's kind of like a double-edged sword, you can say, since it was the first of its kind of a trial, they did have to kind of include everyone, but that was also a downside since you had like such a heterogeneous like population. It's like, really, who is this actually going to benefit? And like you mentioned, maybe with that signal, maybe we should just be focusing on maybe those patients that have, renal dysfunction and focusing on that patient population might benefit. Yeah. And then another weakness as well was maybe 14 days is not enough of a duration to actually see the benefit of SGLT2 inhibitors. Maybe we need 30 days if they're staying in the ICU for that long to see that benefit.
Another cool part is something I always think of, and I remember one of my preceptors, OT, like, you can't even absorb that stuff. Like, you can't even absorb oral drugs when you're that sick. And it's like, I think about that, and I was like, critically ill patients have altered GI absorption. And I ask myself, like, could this potentially impact the difference between my patients where, say, because the inclusion was going to be, you had one organ that's damaged. Well, what if I had a significant amount of people that had a, lower blood pressure or a little bit more sicker, or that we kind of look at that part of it? And is there a different way that we can get the drug to show the benefits? So I'm always thinking about different things when it comes to these sick patients. So I think part of me thought of that, this open label. So think about that as well. So going back and forth with the study, it made me think it was a good one. It was novel in the idea, and we can learn something from this. And I know everyone's getting ready for SCCM and stuff like that. I'm pretty sure somebody's going to have a poster or something of nature on this. So I don't know if somebody's going to have a presentation on it. I don't know. Some people may be talking about this at SCCM. So we'll get this out there around that time.
Another thing also I would mention was like the safety outcomes, because we're always concerned with SGLT2 inhibitors on, DKA and hypoglycemia, infections, and all of that. But we can see not just with this Defender trial, but even the other trials that showed and that studied the SGLT2 in acute illness, really there was not a significant difference between placebo and the group with the SGLT2 inhibitors in terms of those adverse effects. So really, maybe that concern that we have, maybe we shouldn't be as concerned.
Yeah. Yeah. I completely agree with you. Just looking at this and kind of figuring consistently now with all the other studies and with this. So I know I was concerned. I was like, well, these patients are urinating a lot, so their volume is going to be different. That wasn't a big thing. They didn't really have any other major differences that make me concerned. So even certain things that would signal. So if I had no difference, but I had a higher length of stay, I would have thought something was going on. But this trial didn't find those things, and maybe it wasn't large enough to find those things.
Yeah.
And maybe that's something we should look at. Maybe we should look a little deeper into some of those things. But it helps me defend my thoughts of the SGLT2 inhibitors and make me feel a lot more comfortable about the safety of those drugs. So I feel good about that. I think it helps from a kidney standpoint. The mechanisms are there. I think it helps from there. But this study, I can't really kind of have a slam dunk. So some benefits, some things like that. But it really helps me say we should do this again. We should take another look at this. We should dive a little deeper and really figure out these answers, because this is a new world in a sense, kind of test these drugs in these type of patients. Right. That's really kind of the big things from the study aspect of this. Looking at the fact that I can kind of go back and forth and say, okay, the risks, I know some people can get concerned about that, but like, again, this study and the previous ones didn't say that. But continually come back on the cardiovascular stability, the renal protection, the anti-inflammatory properties, all these pleiotropic statin-like properties. Those are kind of the benefits that we should keep. This is why we should study it again. So that's kind of my thought of why we should. And as you mentioned before, there's no harm for the most part we've been able to find. So I'm excited about that. And it's a lot we could talk about, but I don't want to make these episodes super long. So we can kind of look at this and kind of wrap up and kind of summarize the key takeaways from all of the studies, including this one here. So if you had to talk to the audience and say, hey, based off this study, based on everything out there, what's your thought about the use of this drug in the ICU?
Yes. So I would say also based off what the guidelines also recommend and based on the trials that we just briefly talked about, the major recommendations would be, if we don't have really like a major concern for our patients, like they're not in current DKA, they're not scheduled for an urgent or surgery that they're going for, they're not fasting like NPO, and all of those major concerns, then it would be fine to just resume their SGLT2 inhibitors. We actually found that by resuming their SGLT2 inhibitors inpatient, we improve their prescription adherence and them to stay on the medication after they're getting discharged. So in terms of that, just looking at our patient and seeing really, is there those huge red flags that we see? If not, even if they're in the ICU, from these trials we see there's no harm in resuming their SGLT2 inhibitors and even initiating if they have an indication for it, and they could get discharged on it as well.
All right. So one thing that most pharmacists are going to think about is the economic side of these things. And when I consider all the pleiotropic effects in my head, I'm thinking to myself, we can help out in a multitude of ways, and this can reduce overall costs. But I want to speak out of line here. Is there any other cost considerations or economic consideration with using these drugs in ICU?
Yeah. So we can think of the cost like in general when we're improving their prescription adherence when they're leaving the ICU. And we have those benefits that we already have proven, reducing heart failure hospitalizations and all of that. Definitely overall, we can see a reduced cost. So, and we have those patient assistance programs that can also help patients with that cost. So I would say overall, we could see a cost effectiveness with using these drugs.
Perfect. And of course, all my PGY2 residents, everyone's getting to this. This is a prime time for MUE or something. So I'm sorry if this episode gets your precept an idea and ends up being your project next year. So I think that's really good. I think that really kind of highlights a topic that many people are not necessarily thinking about initially. And especially as we think about our critically ill patients, this is going to be important for our ED people, because again, a lot of times we'll have those patients boarding in our EDs now. Again, Today, my ED was filled with ICU patients, and they had oral medications getting ordered. I had OGs and NGs, and I had a patient order these medications today. Instead of me just kind of holding it and saying, I'm going to hold this until they get out of the ICU, this makes me think that we should be thinking about, whether there's a benefit from that. And if my ICU folks, when you guys are rounding on these patients and you ask them what they're on, this potentially can provide another benefit to your patients as well, and making sure that you're on this as they get transitioned to the floor, because traditionally we have sliding scale insulin and that's about it. So we're going to get. So I think we should kind of reanalyze this and dive a little deeper into some of these studies.
Mm-hmm. Yep, I definitely agree. SGLT2 inhibitors are the way to go.
Cool beans. All right. So again, anything you want to say to the audience, any way they can find you, because you're the expert in SGLT2 inhibitors in the ICU. Tell the folks how they can get in contact with you if they want to.
Thank you all for listening to this episode. And if you want to get into contact with me, you can check me on my LinkedIn with my name, Daniella Abi Kheir, which we're going to have linked. And yep, and I'm going to have my email as well linked.
Perfect. Well, again, cool thing is I have an entire little web page dedicated to you guys for this episode. We'll have that stuff set on there so you guys can go check out some of the reviews of this. And key things I want to point out. This is going to be released around the time of SCCM and home in Orlando. I really want to head out there, but I may have to catch you guys virtually this year, but I may can sneak down there. So we got that coming up. So all my ICU folks can go hang out there. For anyone who's interested in the ED world and you want to go to a really, really cool topic, go to a virtual conference, and you want to have an excuse to go to Las Vegas, I know a guy that may be doing a conference in Las Vegas April 4th and 5th called the Empower RX Conference, which is going to be the #1 experience for emergency medicine pharmacotherapy. So you can go and check that out. Again, looking at EmpowerRx/conference.com. I'll put that in the show notes, of course. And you can just reach out to me on social media. I'm everywhere, PharmD _ in the ED. So if you want to be on this episode, if you want to have your own podcast, let me know. We can make something happen. But I'm going to close it out the same way we've closed out all 120-ish episodes that we've done before. You don't have to be a pharmacist. You guys work in the ED, but everything you do, make sure you pharm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.
Perfect.